Janelle White has 10 years experience providing healthcare in the community context and is a registered nurse and experienced in community nursing and palliative care. So I always think palliative care because it was always death by paramedic, but yeah. Intensive care and extended care qualification. She has tertiary qualifications in science, education, paramedicine and nursing, and has several publications relating to healthcare in areas such as chronic pain, diabetes, toxicology, education, Mammalian bites, is that right? Yeah. Mammalian, and zoo noises? Zoonosis, whatever the hell that is. Could someone Google that and advise the chair? I thought zoo noises, she must be living near Taronga Zoo or something, is it? Kookaburra George, something like that. There's a zoo noise. Thank you. And winter is coming. You know, we've got the new season of the Game of Thrones. Winter's coming, but in fact it's going to be winter, spring, summer and falls. Oh, that's such a pun. Comprehensive response to falls. God, there we go. She's got candy here too, in case I need it. So thank you. You're on.
Thank you. Thanks. And thanks, Karen. You're a good one to follow because you've said a lot of things that I don't need to say regards to statistics. The only difference is that ours is New South Wales, so I'm working for New South Wales Ambulance and it's within that context and we're trying to address this problem of falls. So, a prize for naming the two people up there. Oh yeah, there you go. You can give out the prizes for me. Oh, you can earn one in a minute. 1971 they wrote, James Taylor wrote that song and they performed it together. And we have a problem in ambulance and it is falls. It is our number one job. So when people say to me, oh Janelle, I'm the coordinator of low acuity care in ambulance, and if I say that to someone outside of ambulance, they're like, what the hell do you do? Because they think that ambulance, of course, is lights and sirens and high acuity, sexy stuff. And when I tell them that 94% of our work is low acuity, they get a picture that my job's pretty busy. So let me take you through the problem of falls and the solution that we're trying to. Ours is a slightly different tack, but I really enjoyed your talk, Karen. Okay, so this talk's just going to talk about our problem that we have in New South Wales. I'm going to give you a quick view of what we currently do with our falls, talk about how I've gone on to develop this plan that we're now trialling. Actually, we started on the 1st of August, so it's all happening at New South Wales. And I'm going to take you through the package in detail of how we're addressing this problem and a little bit about the trial. So, survey says in New South Wales, how many falls patients do you think we were called to last year in New South Wales Ambulance? The best guess wins. 100,000. Who said that? You don't count. Yeah, but he can have a prize. Actually, he's not exactly correct. It's greater than 100,000 of our calls were from people who've, now it's not going to go. Oh, there it is. Okay, so greater than 100,000 calls a year we receive falls. In fact, it's up to about 110,000 this year. That's breaking it down, as you can see. Nearly 300 calls a day are for falls in New South Wales Ambulance. Let's have a look at some other stats. Similar to your data, between the times of 8 and 9, 8 a.m. and 9 p.m. are our most, obviously people are getting up and then people go to bed. The average age for us is 77 and there's a bit of a split between metro and rural there, but that's population based of course. They're our largest group of non-transported patients. These are falls patients. So of all of our patients, the ones that we mostly leave at home are our falls patients. They are more likely, as similar to your data, to call back within 1 day of the incident call where they first have the paramedic visit. They account for a quarter of all of our non-transport related deaths within 30 days of the incident when they called the ambulance. So that's not saying we're killing them, But what it's saying is that these people are a lot more chronic and complex than one might imagine. Okay, so this might need some describing for people who aren't from New South Wales. These are our non-transport sort of protocols. So a lot of them now, it used to be very low levels of P5. So our P5 is a way that we're allowed to leave patients at home, and it's when paramedics have assessed appropriately and recommend that the patient does not require transport. So we brought this in. It was controversial that we're going to say, actually, you don't need to go to hospital, and here's the reasons why, and it has safety measures involved in it. So 46% of them are left at home on a P5. The others are P2. P2 is against paramedic advice. The patient chooses to stay at home, and we respect their rights to do that. Okay, P7 and P6 are both sort of non-health issues or patient in the care of another provider, aka New South Wales Police. And ECP are our extended care paramedics. And that can be related to a lot of the falls. Some of them occur overnight as well, so they aren't captured by ECPs, they only work 7 till 7. Okay, here's where it gets complicated. So 84% of our current, before the trial started, non-transported patients are just told, when I say self-care, what it means is, so you go home now, Brendan, and you look after yourself. Pop to your doctor. Okay, you'll do that? Okay, good. So we leave the patient to care for themselves with no formal structure in place. Yes, we write referral letters where possible, where the patient consents to that sort of thing. But what we identified was a huge gap. So I presented a talk similar to this to the CEC, which is in New South Wales, the Clinical Excellence Commission. They're a pillar of health. And one of their directors was there, and he was horrified because the CEC are brilliant with falls initiatives in hospitals and falls initiatives in the community. But what we've identified is there's a large gap of people. If we're not transporting 29% of these over 100,000 people who are falling and not dealing with that non-transported number, there's a large gap in care for falls patients. So hence this conversation started last year. Now you're not probably going to be able to read this, but I'm not going to take it through everything. But this is our current protocol. It's called Falls in the Elderly. And basically it takes you through some risk factors and data on this side over here. And then it takes you through a little bit of a point by point, what should we do? Because in New South Wales Ambulance, some paramedics like to read words and lists, and some like algorithms. So we give them both. So in the word list, of course, it asks you to think about other things that might have happened, and it lists things like, oh, was there a head injury or a limb injury? So what we found, though, in ambulance is that actually it made our data collection about falls difficult because paramedics were listing it under a head injury rather than a fall. So that really skews data. So indeed, the data that we have is probably a lot more because they don't tend to write down falls, and we're working on that. And this initiative will address that hopefully as well. We have this current elderly at risk screen, and it's like a frailty screen. And even in that area of frailty with the elderly, it's so complex and everyone's making their own frailty screen. It's hard to determine which is the best to use. But we do have an elderly at risk screen. And again, we need to work on that area because it's poorly used by our paramedics. So then, of course, we move to the algorithm, and it just gives them a decision sort of pathway, and that's kind of where it stops. They can write a letter of referral, they treat their specific conditions, and they talk to the patient about what's best for them. So we realised that together we needed to do something about this, the largest cohort of patients that we are called for, and indeed leave at home after we treat them. So in collaboration with Sydney Uni, with the CEC, with the Falls Prevention Network. So NARI is the National Ageing Research Institute. I've worked with them. And the ACI and the Quality and Safety Commission. I have collaborated with all of them over the last, since September last year, and finally we've come up with this joint plan. And the CEC has been a brilliant supporter in providing us with paper-based stuff to leave with patients as part of our education plan. It's our two-pronged approach. All right, speaking of that. So our new package has this two arms where we're working. And the two arms fall into many categories. So yes, there's a paramedic package and there's a patient package, but it's also aimed at better falls assessment, and there's a public health initiative in there as well, which is kind of a first for ambulance. We're doing prevention and education. Our paramedics are doing that as part of their care, their standard care. So the new package includes a revised protocol, which is currently being trialled, and we were going to call it a falls non-transport, but now we're going to just call it falls in general. And this package needs to be used on every single person that's not being transported to a healthcare facility for ongoing care. So there's no get out of jail free, unless the patient says, I don't want, they don't consent. But this is assumed that this will be done with every patient that's not transported. Okay, so we use this tool now. We're going to incorporate the FROPCOM tool, so it's falls risk in older people, and that's developed by NARI. And together with the CEC, I've worked to incorporate some aspects that they felt were important, and we did as well. So we've included another screen in there and also a checklist at the end, which I'll take you through. So part of that check, we're also going to get paramedics to do strength and mobility testing, very basic stuff and very quick and easy stuff to do. You don't need extra equipment, so it's and it's been received really well by the paramedics. And of course we're looking at changing our tasking. We've had a couple of, let's be honest, some adverse events where patients have called from a fall and they have called co-ord, and they're not a high acuity job, and because cars were busy, they get called off for higher priority jobs, and the patient has been left sitting on the ground for several hours, and it's led to some adverse outcomes. So we hope to trial changing our crawl criteria for anyone who's over 75, equivalent to or over 75, to have. It's not necessarily a one response. For us, it's a 1 and a 2. A 1 response is lights and sirens, and a 2 isn't. But the 2, to get a 2 immediate, which is within sort of 30 minutes, they'll have someone just for an eyes on. So even if they can't stay, like if we're really busy, it could be a manager that comes, helps them up, and puts in another call for a referral rather than leaving someone elderly on the floor to get pressure injuries. And the patient package then includes books where we leave patients with this package of education books. We leave them with a specific transfer of care form to take to their GP, and it also has included an extensive education for GPs through PHNs, or for us they're called primary health networks. You probably have an equivalent in your state, and it's taken a lot of work talking to the GPs as well. So why do we do it? Because we're health professionals, we have an obligation to fulfil the goals of our state or territory health service, but also we have a role, we can play a big role in health prevention, falls prevention, and falls injury prevention. There's savings for EDs and there's savings for future health. All right, so let's take you through, I've already mentioned what they are, so I want to just take you through the new stuff in the package. So if I said to you, here's a question, because hopefully you can't read that well, and I did that on purpose. So this is our new protocol. It's got 3 pages, let's get out there. If I said to you, we need to think about the 5 Ds of falls. When we're thinking about risks, come on now, you're all health paramedic type people, what would be, we love acronyms and things, the 5 Ds and all that sort of stuff. So if someone was at risk if someone's had a fall, what health things that fall under the headings of Ds might they have had? Okay, that fits. It's not one, but it fits. But you can have one. You can. Drugs. Perfect. So drugs is one of them. So adding on to that, what sort of drugs? Okay, psychotropic drugs. In fact, antidepressants are the biggest risk factor in falls. We often think that it's opioids, but actually antidepressants are the biggest risk factor in falls. But so drugs is one, even blood pressure medication and mixing that up. So that's diet. Disease is one. Okay, so there are certain diseases, Parkinson's and things like that. Sorry, someone? Dementia is a disease, yeah, absolutely. That puts a big risk of falls. The other things are diet, so over and under nutrition and vitamin deficiencies, and that's a lot to do with our isolated elderly population. Dysrhythmias is the other D, and of course delirium is a medical emergency. So we need to be able to identify all those 5 things and capture that in some form of assessment. So we've done that. In the prevention stuff, we have It's All About Me. Gee, we love an acronym in health, don't we? And that's about ensuring patients have a medical review. It's about ensuring that they are mobile and assessing their mobility. It's about looking at their medications. Do they need help? Do they need a Webster pack or something like that? It's about exercise and their tolerability to exercise. Environment, assessing the environment as you do with yours. And of course, eyesight. So in that, the protocol focuses on those kind of aspects. And then finally, of course, we have to have an algorithm. So the algorithm's pretty much the same as before, except it's implied if that patient has been assessed and they are staying at home, this FROPCOM assessment tool will be used and the referral pathways will be commenced. So I'll take you through that now. So, again, you probably won't be able to see it, but it's just giving you a visual. I've also got copies up here if anyone wants to come and have a look at them after my talk. So this is the FROPCOM. Now, before you freak out and say, because it's 6 pages long, okay? And the FROPCOM, Falls Risk Older People Community, it's in the community. So community nurses use this tool as well in New South Wales, and we've adapted it for ambulance. So before you start saying there's no way my paramedics are going to fill out a 6-page thing, the reality is that a lot of the information that's in this form is information paramedics have to get anyway. So it's demographics, it's their medications, it's their past medical history. So they're all things they have to record for the patient anyway. And of course, at the moment it's in paper. We do have a view to make it electronic so they can just punch things in and scores will be added up towards the end. So on these first pages there's stuff about services they may already have in place, and for paramedics in our initial sort of little trial where we were getting them to fill them out, we were timing them. So I've timed even my husband, he's a vet, he knows nothing about this sort of stuff. I timed him filling out one on my mother and it took him 12 minutes. And he knows nothing about this form. And paramedics, once they get more skilled at doing it, so paramedics took about 8 minutes, so it's not going to add significantly, given that we should be on scene with patients for a certain amount of time if we're going to assess them appropriately before leaving them at home. Of course, you can see then all the things are covered that Karen talked about in hers. We go down to a falls history, so it gives the history of this current fall and previous falls they may have had. Over the other side is just about their medications, and this is where the scoring, wherever you see a large box on this side, is where scoring comes into account. And these scores they're evidence-based and they're acceptable by medical health professionals in New South Wales as being able to assess whether someone's high or low risk. So over this side you can see scoring comes in with medications, and there are certain, even it helps paramedics who, so if you're not read, because an education package comes with this for paramedics, but of course you know what it can be like. It's often, they're busy. So even if they haven't read the package, it's very easy to interpret this form as you're doing it, as you're going along. Okay, pages 3 and 4. So that was 1 and 2. 3 and 4 goes into sensory stuff. So they look at is there any visual problems? And we used to have the quick screen for our extended care paramedics. It's a falls assessment tool. It's very expensive. It's about $380 a pop. And it was sort of poorly used, and so when they're educated about vision, they just ask them to read a standard document in front of them with their standard glasses, or if they have them or not. So they assess it in that regard. We look at footwear, and this is the addition that we've, cognitive status is in there as well. Now we do abbreviated mental test for every patient that we're not transporting, or we should. So that's, again, not anything extra that paramedics have to do. It's part of their standard. And what the paramedics have said when they were testing this was that, oh, it's actually really good to have things there listed for me, because sometimes you don't think of everything, and when it's listed there, they just can go through it and nothing is missed, so they like that. The thing that we've added in consultation with the CEC was the CAM score, which is a confusion assessment sort of tool to pick up delirium. And we thought that that was a significant thing to try and assess in our patients. So you can see it's just got a positive or negative. It doesn't change the score, otherwise that would alter the scoring system that's already evidence-based. But it makes the paramedic do it when they may not think about that sort of thing. Of course, again, continence is a risk factor for falls, so that is assessed, as is nutritional status. And then we look at the environment, and they're also trained in their package to examine environments and work. Is there low light? Are there mats? You know, are there small dogs running around? Is there clutter? And thinking about services that the patient might need. Of course, then it goes on to functional behaviour, but it's function as well as functional behaviour. So it's their interpretation of how they're doing. Because some people might go, oh, I'm doing fine. And you realise that you go and sneak a look in their fridge. Because as a paramedic, I used to do that all the time when you went to elderly patients, and I just want to pop this piece of paper in the bin. And you know the bin's nearly always in the kitchen. And I'd always peek in their cupboards and fridge. And they say, yes, I'm eating 3 square meals a day and I have steak, and you see their hands are with arthritis crippled. And you go into their fridge and there's a tin of cat food and a packet of Scotch finger biscuits or something like that. So you know that their perception of how they're doing and the reality are often two different things. So moving on towards the end of the form, of course, we do balance and gait assessment, and I'll take you through those briefly. There's some questioning, but these are the 2 of the tests that the paramedics do. How are we going for time? Plenty? All right, we might even do one of our tests. I think you might be my candidate. All right, so the last page of this form is critical, and this is the section that the CEC really wanted on there. So yes, there's a form, but we know GPs are time poor and other service providers are time poor, and they tend to want to only read a 1-pager. So yes, they get a letter with a FROPCOM, a final score, identifying them as high or low risk. But they wanted a checklist for both, and it holds the paramedics accountable, but it also holds the health professional accountable as well. So you can see over this side, these are interventions that might be available. So up on the top, there's low risk sort of intervention. In other words, have you provided the patient with falls prevention? So if they're a low risk category, the paramedics should use their patient package that they have in their cars to take the patient through it and give them basic education about falls prevention. Did you identify medication? If the patient's on 17 medications and they're in a Coles shopping bag, which is what we generally find, and they can't go through them in a logical way, they're up for a medication review. Maybe it's just a quick, call to the pharmacist and they can give you a free Webster pack. So those sorts of interventions go there. And then moving into the high-risk stuff, obviously it gets more comprehensive. But not only is there the intervention, it's how you've solved the intervention as well. So the paramedics need to be accountable for checking off, make sure I've given them. And it also helps them to remember in their busy days. Oh, did I give them the education package? Oh, yeah, I'll tick it there. Yeah, I've given it to them. So it's a win-win as far as making sure that people don't forget in this busy world that we're in. So this is the part that gets sent to the patient's doctor. Obviously, when we get electronic-based stuff, we hope to send it directly to GPs. but currently we have to rely, until we get this platform, IT platform, this magical one that we'd all love, we have to rely on the patients taking it. So part of this trial is follow-up for every patient as well through phone calls. All right, so the patient package includes a specific education and prevention stuff, information, and we have our strength and balance exercises that we do with every patient if they consent. And so far, since the 1st of August we started, I've received, they have to send all the case sheets into me in my office, and I'm entering them on a database, so we're doing qualitative and quantitative research in this project. And I've already received 14, and and they've got to come by internal mail. So I get piles when I get back to my desk every day, which is exciting. A lot of work, but exciting. Also, and the transfer of care plan. So what I'll just show you. This is, I've got one here somewhere if you want to look at it. So the Staying Active and On Your Feet is an initiative from New South Wales Health and the Clinical Excellence Commission. It's really a collaborative effort. It's a 32-page book. It's a beautiful cardboard book. So the CEC has supported us by providing us with tens of thousands of these books to actually physically give to every patient. So they've got something in their hands. So that's the way that they've supported us in this initiative. And all I did was put the contents list there. So you can see some of the things. It gives advice on patients. One of the cool things it's got is a home safety checklist. So the patients can then, because we're hoping that by leaving, and we'll find out through research hopefully, we're hoping that by leaving something there that they might flick through it next time they're having a coffee. But the home safety checklist is where they can go around their own home and tick off things, and it'll help them highlight things that, oh, I didn't know that was a risk, not having, you know, certain type of light in my laundry, or having mats, or wearing these sorts of slippers. So it helps them go through their own home and be the safety police, and it's kind of facilitating them to take charge of their own health, which is always a positive thing. It's got tips on how to get up from a fall if you have fallen, because a lot of people do just call for a hand. But we all know there's no such thing as a simple fall. There is always a reason for a fall. So one of the case studies from this one is a 79-year-old lady who said, oh no, she's in denial about her health, and she's got it all together and she lives on her own. She only fell because a dog scared her, and she didn't see the post, and she hit the post and landed, and she had some injuries. So people have always got a lot of excuses about their falls, but there's always a reason. Why didn't she hear the dog approaching? Why didn't she see the dog approaching on her? Maybe her peripheral vision is flawed. So, and of course, down the bottom there's contacts for people as well. All right, let's do some 1 minute. Oh, we better not. All right, I won't do it. So, a couple of these are the two tests that we do with, the paramedics do with all the patients. They're going to live at home. They do the, oh no, sorry. This is the education sheet that we give patients. Sorry about that. Yeah, this is stuff that they can do on their own, the standing, and this gradually develops balance. And this one's about how to include extra activity in your life by putting your socks in the bottom drawer rather than the top. Because the two biggest risks for falls are balance-related issues and lower limb strength. So we're trying to increase that. That's left with the patient, as well as the Active Healthy website details. Not everyone's savvy on the web in that age demographic, so it's left with them. That's why we give them paper stuff, because currently they're not so active in that area. The two tests that paramedics do before I wind up are the sit to stand, 30-second sit to stand, and the timed get up and go, where they walk 3 metres, turn around and walk back. And they measure strength and balance. And there's scores for those as well. This sheet here, I'm not expected to read it, but this is how we educated the GPs through our PHN. We told them about the scoring system, what we're doing, and how they can help accelerate this program. So the trial's going to go for 12 weeks. As I said, it's paper-based currently, but with a view to technology-based in the future. It's done with our ECPs, so they're adopting it as their entire falls strategy. We're not using the quick screen anymore. And I'm doing trials in metro and also rural with standard paramedics, and they're trialling it as well. There'll be quantitative and qualitative data collected in both patient and the paramedic, because we also need to find out how the paramedics feel about it and what they like about doing it, what they don't like. We're still trying to get them to see that this is their work as well, and that's a culture shift, I think, in ambulance. And that's questions.
Unfortunately, there's no time for questions except this one. Do you think there will be a relationship between Scotch finger biscuits in fridges to falls, the ratio of that?
Yeah, I'd probably use, it's probably milk arrowroots. It's probably not Scotch finger
And can I
biscuits.
say thank you so much for the chocolate koalas. I'm feeling quite sugared up. Could I ask you to put your hands together for an amazing presentation? Thank you so much.